everyone. I hope that you're all doing well. And welcome back to another episode of Hamasat Sahiya podcast. This is a space where we go beyond service level conversations and dive into topics that are truly present in our communities, topics that matter, but often don't get explained properly. Whether it's a medical concern, nutrition related questions, sports science, or everyday health situations, the goal of this podcast is always the same: to bring in trusted professionals who can break things down in a clear, practical, and evidence based way so that by the end of each episode, you're not left with confusion, you're left with understanding, clarity, and a direction you can actually act on. I'm the host of this podcast, dietitian Malak Atwat, and today we're stepping into a topic that affects millions of people globally, yet is still misunderstood by many: refractive surgeries and modern eye strain. Is LASIK really for everyone? In this episode, we will explore a lot of different aspects and the real expectations and risks behind these kinds of procedures. And we'll also take a closer look at the modern day concerns such as computer vision syndrome and dry eye disease, especially in a world that increasingly is dependent on screens. Now, I am very happy and very honored to host Dr. Akshay Mitra, a distinguished ophthalmologist that is recognized for his expertise in corneal and refractive surgery, with more than a decade of experience dedicated to restoring and enhancing vision. He's trained at super prestigious institutes, and he has built an impressive reputation for combining surgical precision with deeply patient-focused approach. Over the course of his career, and please, doctor, do correct me if I'm wrong, he has successfully performed more than 10,000 LASIK procedures and over 6,000 cataract surgeries. Is that correct, or is it more?
Yes.
That's
No,
amazing.
that's correct, actually.
Including advanced premium lens implant techniques that have transformed the quality of vision for countless patients, particularly older patients seeking visual independence. His expertise extends beyond routine care into the management of complex corneal and cataract cases, where his attention to detail and surgical excellence are especially valued. Welcome, Dr. Akshay. How are you doing today?
I'm doing good. Thank you very much for the introduction. Yeah, I guess we have said it is more than the desired number, and more than that is anything, whichever is more. So we are not saying anything wrong. So that's good. And very happy to be here.
And I'm very happy and honored, honestly, that you've given me some of your time so that we can talk more and we can help the viewers in the community.
For
So,
sure.
Dr. Akshay, before we get into surgeries themselves, I think it's important to start from the basics. Now, a lot of people wear glasses or contact lenses every single day without really understanding why. So, scientifically speaking, what exactly are refractive errors and what causes some people to need vision correction in the first place to begin with?
Yes. So regarding refractive errors, if we say about scientifically, I would say that we have three kinds of primary refractive errors: myopia, hypermetropia, and astigmatism. However, since most of the public will be scared by listening to these terms, they will not make much of understanding of it. We will take things in a slightly easier terms and slightly more relaxed language. I would say that there are two components of the eye, similar to a camera. In olden days, there was lens optics, and behind there used to be a reel, if you remember. I guess there was a reel which used to record the picture. So the optic parts is my specialty, where I would say cornea and refractive. Just like a normal lens, we will be refracting the light towards the retina, and the
Mm.
real part is the retina of our eye. So our goal as a corneal surgeon is mainly to put the light exactly on the retina, and rest is the retina surgeon's role or a neurologist role, which will encompass transforming those light rays into a image in the brain, which will we see as a clear image depending on where is the light falling. Coming on to the refractive errors now, since I said that light should fall exactly on the retina, and as you know, no lens is perfect, no cornea is perfect. There will be some form of either the image will, some rays will focus in front of the retina or behind the retina. this will make the refractive error come into action. So if it is being focused in front of the retina, that is the most common refractive error that we see in young children, adults, that is myopia. The powers are in minus. Sometimes it starts getting focused behind the retina. So that condition is hypermetropia. So those are plus powers. And besides that, there is another condition which is known as presbyopia, which is seen in people above the age of 40, where the lens of the eye starts becoming thick, and you can compare it like to autofocus and a manual focus camera. So the lens will not change its shape anymore. In young adults, the lens changes its shape a lot. It becomes thicker, it becomes thinner, depending on where we are focusing. After the age of 40, the lens starts becoming like more like a plastic, and it will not change its shape anymore. And slowly it will lead to either a very good distance vision and a very bad near vision, or a very good near vision and a very bad distance vision. So just like a manual focus camera, the focus will lie on only one point, not on 2 points. We will use this information later to discuss about LASIK and all. But since we are at refractive errors right now, I would say the third thing which we see is astigmatism. Astigmatism arises just due to irregularities in the curvature of cornea. So you must have seen the powers where people say, I have minus 0.5 at 90 degree, I have 0.75 at 180 degree. That is
Yes.
astigmatism. That just says that, okay, the power is in this axis like 180 degree, and the other axis, there's no power. So these refractive errors make up most of the cases in our OPD.
Got it. That makes a lot of sense, doctor. And I love the way that you compared it to how a camera works. I think the language that you used and everything really made it super clear. So, doctor, once someone reaches to the point of wanting a permanent solution, that's where refractive surgeries, I believe, come in. So, when we say refractive surgery, what does that actually mean medically? And how do these procedures work to correct the vision?
Yes, so coming on to this point, that's why we started with the brief introduction like a camera itself. So
Mm.
refractive, if we see the word itself says refraction. Just like physics we studied, there are two things that can happen when light strikes a surface. Either there will be a reflection or there will be refraction. So purpose of a lens is to refract the light. The same refraction in our eye is done by our cornea. That is the frontmost part of the eye, which you are seeing as the black, but in actual reality, it is transparent. And behind the iris is the one which is giving its color. So that transparent structure is responsible for the refraction. And this is most important structure besides the lens, which will lead to the light rays getting focused on our retina. So corneal surgery or a retinal surgery, sorry, not retinal, corneal surgery or lens related surgeries, both aim for both of the surgeries will be same, to let the light focus on the retina. And in terms of refractive surgery, we are supposed to have two different kind of refractive surgeries mainly that are being done nowadays, either cornea-based surgeries or lens-based surgeries. In younger individuals, we prefer cornea-based surgeries because, as I told before, their lens is more flexible. It is like a autofocus camera. It can change its focus. So we cannot remove their lens. Their lens is still giving function for both near and distance vision. So
Mm.
in children, we will do something related to cornea. We will go on to surgeries later on, what all surgeries we can do related to cornea. And however, in older individuals, the same cannot be done with just cornea itself, because after the age of 40, as I said, the lens becomes rigid. And no matter whatever you do on cornea after the age of 40, the lens will remain rigid. So you cannot give both visions to the patient until and unless we remove the lens itself and replace it with the multifocal lens.
Okay, so with age, a replacement is quite needed.
Yes, so it depends on the age, what kind of surgery we prefer. But I hope I
Perfect.
made myself clear regarding the refractive
Yes,
surgeries. Yeah.
yes, very much. Thank you so much. Now, of course, doctor, now to elaborate on your point, whenever people hear the word refractive surgery, the first thing that comes to mind is LASIK. It's probably the most talked about eye procedure worldwide. So, may I ask, what exactly is LASIK and why has it become so popular compared to other vision correction options out there?
So first we'll go with why it is so popular, I would say. It is becoming so popular nowadays because it is completely a non-invasive technique. You can call it non-invasive. We are not
Mm,
entering the eye practically, and the recovery is right on the next day. So there are very few chances of complication as well. And as a matter of fact, I personally have got my LASIK done around 12 years ago by my dad, and
really?
I have myself done it for my brother as well. So it
Oh,
is that common in our family. We are also always doing it for us as well. And coming on to what is the surgery about? As I told before, it comes under the category of cornea-based surgeries. So in younger individuals, we do cornea-based surgeries. Whatever LASIK, SMILE, femto-LASIK, whatever the procedure, it will all change the shape of the cornea. So LASIK is mainly responsible for changing the shape of the cornea in a manner that the light focuses perfectly on the retina. And if you want to know the types of LASIK and all, we can go on with that, but it will take, I guess, too long for very small categories of LASIK. However, just to make a broad list, there are blade related LASIK, in which first step, that is the creation of flap. It is done by a blade known as microkerato. And one of the latest techniques that we are doing is femto LASIK, where the flap itself is created by another laser. And besides that, we have SMILE as well. SMILE is also a promising procedure, something which is done entirely by femto laser. However, personally speaking, I have seen way better results with femtolasic as compared to Smile, and I do prefer Smile as well in cases which are slightly on the lower corneal thickness side and somewhat which are not very much fit for femto. However, still femto, I would say, is still considered as the gold standard for LASIK by most of the refractive surgeons.
okay, got that. So these are, doctor, these are يعني well, let's say techniques more related to, or what exactly?
Machines are different for all the procedures,
Machines.
but
Okay.
overall its aim is same. Any do We do change the shape of the cornea and help to focus the light rays at the retina perfectly.
Okay. So the technique is the same, but different machines that are being used in a way. So, doctor, despite how common LASIK has become, we also hear a lot of specialists that say that it's not really suitable for everyone. And I think that surprises many people. So why isn't LASIK a universal solution? And maybe let's say why are some patients, not going to be the perfect candidates for it?
Yeah, so just like now I said that some people who are not fit for femtolasic, I prefer smile in them. So there are many things that need to be considered, and that is something we learn a lot as a corneal surgeon, how to respect cornea. So we need to study the cornea in detail before planning for a LASIK procedure. It should not be done in anyone because not everyone is fit for LASIK. We see cases where people went in for LASIK and probably they had -4, -5, but the cornea clearly showed signs where it could not take that much of correction and it was not thick enough, and it could lead people ending up with powers like -12, -15 later on after the procedure, say 3 or 4 years later. So it is very important for a cornea surgeon to assess the scans before the LASIK. So first and foremost thing I would like to start is with the scan. So first and foremost thing that is important is corneal thickness and
Okay.
the regularity and the shape. Not everyone is fit for the LASIK, and most important thing in all three factors is the thickness. So if the thickness of the cornea is not very good, we should not plan for LASIK. And coming on to the basic criteria besides the doctor related things, that is age should be 18 and above. That is very important because till 18, if you see for small children, the powers keep on increasing. So usually they will start at somewhere around the age of 10 or 12 with -1, -2, and they'll keep on progressing till -3 or something like that till 18. So usually we see till 18, the child is growing and the powers are increasing. And I would like to make it very clear that with LASIK, we can correct only the power which is there at present. Suppose the child is having -3 at present, I can correct that. I cannot predict the future that how much will it become later on. So even if we do it under the age of 18, and tomorrow if it progresses, it can come back, and it is not recommended to do it again and again unnecessarily. So the FDA guidelines and the rule book is simple: do it after the age of 18. And second most important criteria is, since we see in some individuals the power increases for 1 or 2 years after the 18 age mark as well. How to assess that is, the second criteria says that either the age should be 18, and along with the power should be stable since last 2 years.
Oh,
So we compare the powers of last 1 or 2 years. If there is a change of say minus 0.25, minus 0.5, that is acceptable. That much variation is seen with person to person examining the child. However, if the power is increased by say more than 1, 1.5, we always advise a child to wait for at least 1 year more or 6 months more to just see how much there is any progression, if there is any progression. If there is no progression for another year or so, and we can easily say, yes, the power is stable since last 2 years, then we proceed with the procedure.
okay, got that. So it has to be, consistent for the past 2 years at least.
Yes.
Doctor, so for these patients who are told that they're not suitable for LASIK, that definitely doesn't mean that they're out of options, right?
Yes.
There's like different alternatives. Could you walk us through some of these alternatives that could possibly be offered to these patients?
Yes. So for people, first of all, if there is very, say, minor difference in corneal thickness, it is not acceptable for LASIK. First thing that we do is the PRK procedure.
Mm-hmm.
And in PRK, the first step in LASIK is creation of the flap. We make a flap. We cannot do LASIK on the topmost layer. If we do the LASIK on the topmost layer of the cornea, there is more pain. It takes almost a week to recover. So we usually create a flap on the topmost layer. We lift it and we do laser on the stroma and we keep the flap back, something like
Okay.
that. But if the patient is completely unfit for LASIK, this flap thickness, we conserve it and we do the laser on topmost layer as well. And we put contact lenses on for those patients, and they spend around 1 week in recovery. It takes roughly around 1 week, and it gives decent result. So this is like for mild thinning, you can say, which is not acceptable for the LASIK parameters. And there are many cases, and these are the cases which I like doing the most, I would say, because in those I can see real changes. I've literally seen some of my patients even crying immediately after the surgery by seeing so
Oh,
clear, are the ones who had minus 14, minus 16, those kinds of power. And I've been seeing at least 1 or 2 cases of such a kind every month. Even last week also I have done one of the cases of those powers. These are the individuals which have been refused by most of the refractive surgeons for, at least in Dubai, I would say, for LASIK, and they are not fit for LASIK for sure. And for them, the good procedure of choice is always ICL. So, as I told you before, we can do only two things for the refraction to be complete. So, either touch the cornea or touch the lens. And since the child is young, we cannot touch his lens as well because it is still giving us near vision. It is still working like a autofocus camera. So what we do in these individuals, we implant another lens on top of the natural lens of the eye. So the lens which is inside the eye is completely functional, and we implant another lens on top of that. That lens is known as implantable collamer lens. That is the full form of ICL, and the best quality is made by only one company, that is Star. It's, I think, most likely Switzerland based company, and we implant those lenses, and we have not practically touched the cornea. Even if the cornea was thin, the child will not end up with, say, complications related to doing LASIK on thin corneas, and the natural lens is also preserved, so near vision is intact. So that is the procedure of choice in individuals who are going having power of more than minus 14. And there is one another category in patients who are above the age of 40, I would say. Above the age of 40 and high powers, or even if moderate powers, they will have now the stiffening of the lens. Now the lens will start becoming slowly cataractous, say by the time they turn 50 for sure. And for them, we remove the natural lens because, as I told before, their condition that is presbyopia. Now the eye is more like a manual focus camera. It will stay at one focal point.
Mhm.
So in that case, I would say the lens is not serving us much of a purpose. So we remove the natural lens and we implant an artificial lens, especially if the age is beyond 50. We should not think about LASIK. We always should plan lens replacement itself, because even if we do the LASIK, near vision will become blurry. So they are not usually happy. The purpose is defeated. You have to wear glasses. And then nowadays there is one more technique that is being done. I have done it myself as well with many individuals, but the results are, you can say, dependent on the occupation of the patient and how much driving he is doing. That is known as, in one of the eye of the patient, we do slightly refractive correction with laser, which will focus towards far, and the other eye, we do correction which will focus towards near. So both eyes combined will show you near and far both. However, it will give you a good result from the age of 40 till 45. Once this patient also turns 50, his near is going to deteriorate for sure.
Oh, okay, and then in that situation, would they have to go for another surgery to fix it?
Later on, yes, cataract will be, lens replacement will be needed. We call this monovision, like one eye is for far, one eye is for near.
Okay, I get that now. How amazing has, like medicine and all of the, different techniques that are used has become. The amount of different approaches and everything that you've mentioned is honestly mind-blowing and life-changing. So, doctor, I want to talk about the honest expectations, because social media sometimes and the people that go on it makes it seem like these surgeries are overly simple or completely risk-free. So from like a medical perspective, what are the potential risks or side effects that the patients should know about, and what should recovery and results realistically look like after surgery?
Yes, that is very important, like setting the expectations straight. And I would always tell my patients that never expect you will have perfect zero with zero diopter. We end up maybe once in 100 cases, once in a while, we see, okay, perfect zero is there. But usually you will end up with powers like minus 0.25 or plus 0.25, or maybe plus 0.5 or minus 0.5. That much powers will be there. Our main aim will be that patient should be able to see whatever he is seeing with the glasses, he should be able to see without the glasses. So that is the main aim, and both eyes combined, usually we achieve that. In terms of complications, I would start with the minor ones first. Basically, most common ones that we see are related to either overcorrection or undercorrections. Those can happen sometimes, but I'll make it very crystal clear that never in LASIK there'll be any complication which will end up, um, which will lead to the patient end up getting blind. Most common scare is that what if I lose the vision, whatever I have. Always with the LASIK, the vision would be better than what it is in currently if the LASIK is done correctly, considering all the factors in the cornea and everything. And so the first and foremost is undercorrection and overcorrection that can always happen. And once in a while, if it happens, after 3 months of period, we polish the cornea. We do another procedure known as polishing, and it improves the vision to full. Yeah. And besides that, we don't see much of infection related cases because it's outside the eye. We are not entering the eye at all. And later on, somewhat flap related complications are known, but they're all manageable. It's not something which would affect the patient noticeably or he will notice any changes. It's just surgeon related. It happens like flap, as I said before, it can move from its place, but we can always correct those. Like when we place the flap back, usually patients they don't notice on their aspect. However, after the procedure, I would say things happen. Like sometimes I have seen the flap completely getting dislocated,
Oh,
and that happened only so far in last 10 years. I've seen only two cases in whom this thing happened, probably after the 4 or 5 years period of the LASIK. And one of them was an army officer. He had it with a gun recoil. So it needs that kind of power to move the flap. And the second one was a boxer, like professional
Oh,
boxer, and he had a punch on his eye. So as far as I think in common life, no one would be getting injury with that much force. So nothing happens. And in those people also, the flap moved, we placed it back, everything returned to normal. So that's
doctor.
pretty much it. I don't, so far, like I'm talking about the complications which we encounter. However, if we go by the book, there are endless
Yeah, that's
complications
true.
and many things can happen. But these are the ones which I'll be honest about and they happen. Unless if we go, then those things come on the skill as well. Usually at this present time with the more sophisticated machines, until and unless something grossly negligent has been done, I don't think there's a chance of any complication.
Got that. Doctor, you've mentioned overcorrection. Can you elaborate a bit on that? Like, what does it exactly mean to overcorrect the vision?
So overcorrections and undercorrections both, what happens is suppose a patient is having -3 diopter of refractive error and we put in the value as -3 and we are expecting the patient to have power of 0 afterwards and patients end up with +1.
Hmm.
So technically the machine corrected instead of -3 a -4. So it can happen due to many reasons. Firstly, maybe while checking the refractive error in the OPD before the surgery, the patient could not say very clearly which one he is seeing more clear. Like when we replace the lenses, we ask the patient, can you see more clear now or now? So maybe the patient could not judge properly. Secondly, maybe the machine had some errors or something like that, but not major. Like I would say out of 500 cases, maybe once or twice these things can
Oh.
happen. Or sometimes I would say while doing the procedure itself, the patient might move the eye a lot. Little bit movement is fine. That can be traced by the laser. But if you are moving like literally your head from side to side, you're not able to stop your eye movements, then yes, we see overcorrections and undercorrections. And this movement related problems, they mostly happen in people who have higher refractive error. Why? Because when the refractive error is high, definitely the machine is going to take longer for the laser to
Oh.
operate. So the longer time you'll have to keep your eyes looking up and open in one direction, the more chances are there for the child or the patient to move his eye.
Mm-mm.
Once there is, say, an overcorrection of, say, 1 diopter or 1.5 diopter or an undercorrection of 1 or 1.5 diopter, it will hardly take 5 seconds of laser to correct it later on. So we can always do polishing after 3 months if that is the case. And usually they are happy.
Okay, got that. That sounds pretty clear. So, doctor, let's talk a bit, or let's shift a bit slightly from surgeries to modern lifestyle habits. We're living
Mhm.
in a generation that spends hours daily on phones and laptops and screens. Recently, we've been hearing much more about something called computer vision syndrome. So, what exactly is it, and why are younger adults experiencing eye strain more than ever today?
Yeah, so I guess it is a video podcast. If we go back to the last 1 or 2 minutes itself, I would like everyone to just focus on how many times we have blinked our eyes while staying on the computer. So normal blink rate is more than 35 to 40 times as well in individuals. It should be more than 30 times at least. And unfortunately, while using screens, computer, TV, whatever the thing, our blink rate reduces a lot. So why I'm focusing or stressing too much on the blinking part is because there are glands, oil-based glands that are on the upper lid, and those are known as meibomian glands. They secrete the oil layer of the tear film, and it is secreted only when we blink. So the oil is removed from the expelled or removed from the lids. So lower blinking will lead to blockages of these ducts. Slowly, the ducts will get blocked and the glands will get damaged. And once
Oh,
the glands are damaged, the oil layer is not there anymore. So we call this particular form of dry eye as the evaporative dry eye. Only the water layer and the mucin layer of the TL film will be there, and this water layer will just either come down as tears a lot or it will get evaporated very fast. So it's kind of like a paradox. Only the patient is telling you, no, I have constant tear in my eyes, and I'm telling the patient, no, you have a dry eye. So they are not ready to believe also they have a dry eye. But then once we teach them, okay, this is the difference. oil layer is missing and you have to do certain exercises to prevent that, then they understand those things and they are relieved by that as well. Coming on to computer vision syndrome, first of all, this is the oil layer which is deficient and lack of blinking. Then is the general stress. Continuously, eyes are staying open and they're focusing on a screen. There is a UV rays that are entering. Some people these days are saying that blue light is not comparable to rays, but nevertheless, they are stressful for the eyes. And besides that, there are certain rules that we need to follow. If you just open on details on computer vision syndrome, I just tell the individuals to focus on 20-20-20 rule. Every
Hmm.
20 minutes for 20 seconds, either look 20 feet apart or just close your eyes. That is the most important thing to follow. And I always advise some of my patients that you can just create a habit. If you are clicking somewhere, just with a click only, blink your eyes wherever you click. So I personally do it. Like if I'm clicking 10 times for one patient's file, here, there, I just close my eyes with the click and make it a habit. It happens. It becomes, initially, it will be like, okay, you are doing it purposely, you are doing it forcefully. Later on, it will become automated for sure. Apart from that, use eye heating pads if possible. That is very good. There are heating masks available on Amazon. Easily, you can buy one and just put it on your eyes for 10 minutes. After that, once the heated part is done, just squeeze your eyes so the glands open up. And one of the most important things I would say is never operate computer in a dark room. It,
Oh,
always the light should be more than the screen light. So surrounding light should be more than the screen light. Keep the brightness to 80 to 90%. Never keep it 100%. That will harm more. And there are nighttime reading modes in Apple. I think there is reading mode. In Android, there is night mode. In PC, Windows, there is night shift. Use those modes. They help a lot. They help a lot with the stress. And still, if people say that their screen time is way more than 8 hours or 9 hours, then we have to give them certain lubricating eye drops as well to keep the eyes lubricated and keep the cornea safe. So that's pretty much it. The preventions for computer vision syndrome. Regarding the syndrome itself, it will present as headaches, tired eyes, and lack of sleep as well. Because at night, if you're using screen, we have lower secretions of melatonin in the brain, which is a sleep hormone, and our brain will keep on thinking as if it is still day, and our sleep will be lowered. I always advise people to stop using all forms of screen before at least 2 hours before their planned sleeping time. Nowadays, we should focus more and more because the stress is increasing. We should focus on sleep as well as a treatment of all the illnesses because it is one of the main causes. So, if the sleep is good, everything becomes normal automatically.
with that. Thank you so much, Doctor. I was about to ask you for one practical advice, but you've given us so many, and honestly, I'm amazed by so many of these. But just to touch up on one point where you mentioned if you're writing the notes of your patient, you're with each click, you're closing your eyes. So what's the practice like? You just squeeze your eyes closed and you open it? How do we practically do it?
Yeah, yeah, you try to blink as frequently as possible. It's just my method that I tell patients that you can do anything you want, maybe a click, maybe when you send a mail, or maybe whatever you do frequently. I guess clicking is something which we do most frequently while using computers. Like at least you'll do 2 or 3 clicks in a minute. So at least 2 or 3 extra blinks is a lot. Maybe more, maybe at least 10 times people will be clicking somewhere.
That's very
If I
true.
say for my file, if I have to open one file, I am doing at least 20 clicks, I would say.
Oh, got that. That's a really nice way to get the best out of it and do all the blinks. Thank
That's
you.
all you can do, yeah. Yeah.
Thank you so much, Doctor, for all the details that you've shared with us and all the knowledge that you've shared. You've explained it honestly in a very simple yet informative way. So I really do appreciate it.
Thank you. You're welcome.
And I want also to add one thing for the viewers. I've known Dr. Akshay Mitra from my dad, who has also been a patient of his. And my dad did his cataract surgery with him. And he's honestly very happy and very satisfied. And he even told me, you really need to contact Dr. Akshay so you can do a podcast with him so people can actually benefit. He's an amazing doctor, has great knowledge. So I am very happy about this opportunity. And I'm very glad to have hosted you on this podcast.
Thank you much. I'm happy to be here as well. Like regarding, I would say it's a very good thing that you're doing with the podcast. It's something similar what I do with my patients. All my treatments, I always ask if this condition is with my family member, whether I would be doing this thing or no to him. And I guess that's how you also selected me. If this doctor has operated for my dad, we should put him on the
Exactly.
podcast. Happy to do
Exactly.
that. Yeah.
Very ethical and honestly, and you tell your patients what you really truly think is the right thing, and you're super empathetic as well. So that's a really good point. Thank you so much,
Thank you
doctor,
much. Thank you.
and I hope you have a great day. Thank you.
Thank you. Have a nice day.